CME and CEU are provided for this event, and see your email and website for details after this presentation. The didactic today, we're super excited. It's kind of a different way to shake things up. We've got our own team members, licensed clinical social worker Allison O'Donnell and registered nurse, Mary Lee Peterson-Engel as our guest speakers today. We're really going to focus on complex care coordination, so we'll go over kind of some ideas of how we do it here in palliative care, and really looking for feedback or supplemental information from other teams so that we can kind of tighten up our process. If you have any questions about today, just if you could wave your hand and let us know. We would really like to have this as an interactive discussion today. We have up until 12:05, and so I will start it to you ladies, and I will let you guys know that when you want to advance slides, just say next slide. Okay.
Well, welcome. Today's presentation is on complex care coordination. Our objectives for this presentation is to define complex care coordination, to identify needs for patients with complex illness and formulate a plan of care prior to discharge, to identify resources for patients with complex care coordination needs across Alaska, and to identify the communication pathway for end-of-life patients at discharge. So we'll just talk a little bit about complex care coordination. Our hope is to provide a tailored plan for patients with complex illness. This includes family and other caregivers to provide care to the patient. Of course, identifying caregivers, identifying and coordinating resources here and in other communities, to identify barriers to care, to coordinate follow-up appointments. Identifying barriers to care is something else that we look at when we're tailoring a plan for complex illness. Of course, coordinating follow-up appointments, completing advanced directives and Comfort 1 is one of our goals. Assess patients and family needs, address symptom management, identify and coordinate supplies needed, communicate handoff of care to a health aide, a primary care physician, answer patient, family, and care team questions. Boy, that seems like a lot.
It is a lot. I just wanted to make sure that we had the slide up here. So just to give everybody a little bit of a breath to read that here.
Yeah. There was a lot to say. The next slide talks about what is the plan for discharge. And some of our considerations for planning for discharge is the patient local? Are they discharging to Anchorage, Eagle River, Wasilla, Palmer, or Girdwood? Is it a regional village? Is it a larger village or a hub community? Those are some really important considerations when thinking about discharging patients home. Next slide. What is the plan for discharge? Is the patient an end-of-life patient? Does the patient require assistance in the home? If so, does the patient require bathing, toileting, feeding, assistance with ambulation, medication administration? Do they need durable medical equipment? And is the patient discharging home here locally to an assisted living home, to their home community, or perhaps even on hospice or home health services? Something else we consider is resources. Who are the caregivers and what is available? Do they have caregivers? Is the family available to be a caregiver? It's really important first to identify what kind of community support do they have. Do they have spiritual support, family, friends, possibly Medicaid services for PCA services? Home health, are they residing in an assisted living facility? Do we have community health aides that can help with some of the discharge planning? Primary care physicians and their involvement. and of course video teleconferencing as a resource. Of course, if they're local here, we like to look at the local resources first for discharge. South Central Foundation, including the primary care providers, are they eligible for home visits from that program, from their home-based services, behavioral health, wellness programs such as talking circles and perhaps elder programs. We look at local home health agencies and see if they're eligible for those resources in the home. If they're appropriate, if they're an end-of-life patient, certainly we look at Medicare hospice. We have 2 here in Anchorage. There's also one in Matsu. And we have a volunteer hospice, Hospice of Anchorage. Some local resources that we look at for DME and loan closets are Access Alaska, Hospice of Anchorage, and Turnaleaf, which is in the Valley. We think about assisted living facilities and PCA services if the patients are eligible. We also think and wonder how we might be able to qualify them for those services. And then we also look at Medicaid care coordinators and the programs that fall under that category. Some other considerations that are challenging is oftentimes regionally and in villages, there's very limited access to hospice services. There's also limited patient care services such as PCA and supportive services. Primarily it's family and community health aides that are responsible for much of the care. Sometimes there's miscommunication from inpatient providers about discharging patients home on hospice. Oftentimes there's not hospice in those communities, so that's something else that can be really challenging.
So I'm going to do the next half of the slides. So when people are discharging home to next slide. Okay, so when people are discharging home to a hub or village, at the end of the life, we kind of like to go through a checklist. Some of the things that we like to consider is, if at all possible, we like to have the patient set up a follow-up with their primary care or palliative care before transitioning home.
Right now, and then if in the event we do run out, you can always say, hey.
Oh, sorry. Another consideration is if they're a pediatric patient, we like to consider the local follow-up with Team B at South Central Foundation in the outpatient pediatrics prior to travel to a village or hub, and that's the RASU, Rural Anchorage Service Unit. The other thing we like to do is coordinate video teleconferencing for patients with their primary care or oncology or palliative care or other specialty clinics if it's needed. One of the other things, as Allie had mentioned earlier, is especially if these are end-of-life patients, we want to consider having them fill out an advance directive, or at least at the very minimum having the family oriented in the use, and then to document it in the chart and scan it into the chart. And then if it is completed, we do want to make sure that the local clinic has a copy, that the regional primary care provider has a copy, and that the patient and their family has a copy. Next slide. And this is another thing that we like to have completed is the Comfort One. Again, if we can't have it completed prior to their travel back to their village, we at least want them to be aware of it. And if it is completed, then we'll document it in their chart. And again, a copy provided to the village, the primary care provider at the hub, a copy for the patient to post on their refrigerator, and then we usually keep a copy too in clinic. So other things too that we want to consider is the patient and their family. As Allie had mentioned earlier, a lot of times when people are traveling home to these villages, it is the family who is providing the care So we want to make sure that they're aware of things that they need to be looking for, any sort of assessment, any sort of education we need to provide to the family regarding the care of their loved one. We want to go over the medication list, and this is both with the family and the patient as well as with the village and the region. We also want to go over things that have been addressed on their ESAS as far as their symptoms. Pain is always a huge one, and one of the big issues with patients discharging to these villages are the narcotics. So we want to make sure that pain is managed and that the caregivers aren't afraid to give them pain medication and they know side effects to look for. And then we'll also go over comfort pack supplies that they're going to need. Often these villages don't have a big surplus of supplies. So not only are we making sure that we're sending things home with them, but we also want to communicate to the hub that these people are going to need supplies in the future sent out to their village. And again, about providing education for the patient and family as far as medication administration. A lot of these family members are really overwhelmed at the idea of having to give their family members these medications, and it's really intimidating, as well as talking to them about just the safety of having like a lockbox and keeping them away from children and having a logbook and documenting medication. So one of the other things that this was back to the symptoms and the ESAS form, is it's really important that we are proactive on the management of symptoms. Pain is, and especially these end-of-life patients, pain and anxiety are really, really huge, and we want to make sure that again, that the village has the medications available for the patients, that they have a supply, and the family is comfortable administering. It's also, anytime we have those pain medications, we want to make sure that they have a bowel regimen. And then again, with those side effects, nausea, make sure they have a good toolbox to manage nausea and shortness of breath. And one of the other things on managing these symptoms is also talking with the village health aide about symptoms that we are expecting this patient to have and how comfortable they are managing it and what medications and resources they have available if they feel like they're kind of stuck on managing the symptoms. We also, if they're a palliative care patient, we like to make sure that they have our phone number and they know that they can reach out to our nursing, Karen and I, or our whole team. Narcan is the standard now, anytime sending people home with pain medication, so also making sure family is aware of that and the use. And then making sure meds are as concentrated and that they're safely able to avoid sending large amounts of home with the patient. And there are restrictions. I know on inpatients, they're only allowed to send patients home with a 2-week supply. So we also need to, it's really important to communicate with the village and the hub as far as getting that next supply of their medication. And then, does the pharmacy formulary support medication sent home with the patient? This is huge. A lot of our village pharmacies are really limited to the narcotics that they carry on hand. A lot of it is liquid morphine, and typically a lot of our patients get discharged home from the hospital not on liquid morphine. So that's a big, huge factor. And I think it's also a lack of knowledge between our inpatient and our outpatient villages. Next slide. So other things that we want to consider is things that comfort supplies and supplies that they're going to need that probably aren't readily available. in the village. And again, the village may have some of these supplies, but they probably have to order them from their hub. So making sure that they have stuff for incontinence and enough to supply until they're able to get their next order. And again, with these supplies, it's really important to communicate back to the regional hub that they're going to need these supplies, because in general, it can take a week to a couple weeks to get these. So chucks, pads, gloves, bedpans, donuts, toe crushers, plastic med cups, syringes, maxi pads, swabs, toothpicks, batteries, fans, emesis bags, and sure, medisets. The list could go on. And then this again talks about what I had mentioned earlier. This is really, really important. A lot of times these end-of-life patients are too sick to manage their own medication, so really it does fall back onto the family member. Sometimes a health aide is able to come into the home, but it's limited. So making sure that family is really has a good understanding of the medication, they have a good understanding of the symptoms, how often they need to administer it, and again, keeping a log, because a lot of these people are on quite a few things, and sometimes it can get confusing to remember when you gave the last dose. A lockbox is a huge thing because we do have lots of issues with diversion, and then as well as a lot of these homes have multi-families, and we always need to be thinking about child safety. And again, that goes with the lockbox goes back to the diversion prevention and also education in the family, talking to the family about these issues and getting them really thinking about any family that they think could be at risk for trying to take these medications, and making sure that they're taking preventative measures just to be aware. And then talking to them about proper disposal when no longer needed, and then refill procedure, when and who to call. So this is huge, and also in this piece, making sure that they realize that when they need a refill on the medication, they can't call these villages or their village health aide the day before. This is usually going to take a minimum of a week. So they really have to be proactive on the amount of medication. So again, this is patient and family caregiving knowledge assessment, and things that we need to consider. We need to let them know that there are, there's probably going to be some skin breakdown, some bed sores, and again, supplies that they're going to need, and how to care for these wounds. Talking to them about decreased appetite and thirst, that these are going to be expected, some agitation, bowel and urine regimen, and what it's going to look like. Because a lot of these people don't know that, these functions are going to decrease, and it's not going to look like it did initially in the hospital. Planning ahead again for the pain. And then, what can we do to help, and what we can't do, and what they're not going to be able, they're going to have barriers to being able to help them with everything. So this is, again, this is about the handoff. This piece is really, really important, and this needs to happen inpatient as well as in the clinic. It's important to physically call the village or the hub and identify who the primary care provider is and who's the RN case manager. It's important to usually have a verbal conversation with somebody, not just sending because it doesn't mention on there sending the last chart note med list, but it's really important to actually have a one-to-one conversation about the patient, and letting them know that this is an end-of-life patient, and this is what we've seen so far with this patient. This is what we're going to expect. Oftentimes, it's good to talk with the village health aide and talk about their experience with that, and is this something that they're actually able to handle, and do they feel supported, and making sure that the primary care and the RN case manager both have the contact information for the village health aide and vice versa. So again, this is on the handoff, and I kind of sound redundant because they kind of go hand in hand. Again, talking about the community health aides. These are our frontline players on these end-of-life patients, and it's really important to ask about what sort of support they have there in the village, what kind of social support they have for the family. Oftentimes, these health aides are family members themselves, or they're related, or they're friends, close friends, like our distant cousins. So these are things to consider. Talking with them about the diversion and what DME, durable medical equipment, might be needed. Often there aren't these supplies in the village, and a lot of this is coordinating the village health aide with the regional nurse case manager to try and see what sort of DME they can get there. And the other thing is asking the health aides, is there somebody in the community that has any of this equipment, so those are important things to think about. And then again, clarifying that the community is ready and comfortable with taking care of this patient, and identifying, so usually there is a provider that's covering the village, so identifying who that provider is and who that RN case manager is responsible for that village, and making sure that all parties have those contact numbers. And then again, relaying the medical information of the last chart note, the medication list, any scans. Phone calls are the #1 way of communication, and emails are a good pathway of communication as well. So this is a huge piece back to the medication. It's really, really important to verify medications on formulary in the village and the regional regional formulary. Are they available? I can't stress how important this is, because again, these inpatients are often discharged on medications that aren't available. So what happens is these patients are sent home to villages, and then they're left having to manage the pain with liquid morphine until medication is available. And then how long will the regional pharmacy take to deliver the medications to the village? And I think for most of the places that I've talked to, it's usually a minimum of 3 days, and then whether it could take a week plus. Yeah, and this is, again, talking about how often do the planes come in, and this can, always be weather dependent. How will the patient and family receive support? Some community health aides will do home visits. Some primary care physicians will do home visits, and then always coordinating video teleconference with either palliative care or other specialty clinics, or even their primary care. And then making sure the patient and family has contact information for their local providers and when to call, and basically making sure everybody's able to talk about the plan of care and some of the things that might come up. Next slide. And then, again, this is talking about who will do what for the patient, who is their support. Again, this is usually family, friends, the community, the health aide. And then a follow-up phone plan and a video teleconference. That's if internet's available. We do like to do direct video teleconferences to the home. again, if that's a available resource. And then looking at any barriers that they might have, any physical. Sometimes these people are too sick to get into the local clinic, and sometimes they don't have the internet to do the direct video teleconference. So oftentimes we are talking with families on the phone. We're having video teleconference with the families regarding symptom management, and really getting them to work with their village and their hub. Do they need DME? What is the process? It's always easier to do this before leaving Anchorage. You know, once they're home and they're trying to get things sent out there, it's kind of working backwards and very difficult. And then it's important to take time to answer questions on what family might think they're going to need, what they think might be helpful, and then always reinforcing that we're giving them our contact phone numbers, our palliative care phone number, and again, that they're able to teach that back to us. I think that's it.
Yay! Okay, thank you very much, guys. That was a lot, and it kind of details what in the back 40 the palliative care does and how busy our staff and team can get, which is why we're a consult service and we don't particularly take over care for patients, and we work really closely with our ancillary teams in the regions because we need their support just as much as they need ours. I'm really interested to hear if anybody has any comments or thoughts, pitfalls, worries, celebrations, anything that they would like to share for discharge coordination, anything you need. Okay, I see some hands waving in the ANTHC conference room.
Hi, this is Lina. Hi, Rana. I think one of the things to always keep in mind with developing these complex plans is that often they really can only be as good as your relationship with the patient is. I see staff work very, 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 very hard and develop incredible plans of care, but there's a disconnect with the patient, and so then there's frustration, you know, with them feeling like the patient's not doing their part, but maybe the plan of care didn't take all of their considerations or preferences into consideration. And so to always really be mindful of the relationship that you're building through the process. And when you have a good relationship, there's a level of transparency there that they will share and trust in a way that if it's contentious or there's lack of trust, it can really erode the best of discharge plans or care plans. So I would just encourage us to keep that in mind.
That's really great insight, Lina, and thank you for sharing that, because as you mentioned, if you don't have that trust, building that trust is super important, because that will ultimately keep people where they want to be. It keeps them out of the hospital, keeps them out of crisis, keeps the stress level down. So what a wonderful point for sharing. Thank you. Oh, hello, conference room number 3.
This is Nancy. Hi, Rana. So,
Hi, Nancy.
this is we had a fire drill in the SCS building.
Is that way?
In the PCC.
Okay.
Oh, I'm surprised there aren't more people here. They kicked us out. So, you know what? This is an old nurse thing, but I always try to find who's the worrier in the family picture. Who's the worrier? And because the worrier, if you get them on board, and you know, they may not, a lot of times they're not the primary caregiver, but I've had a worrier come to me and say, this drug kit, does that mean they're going to go off all their other meds? And like, so these little tiny things that they could have brought up, but they didn't. But get the worrier involved and get them.
Yeah.
And once you got them on board, oh my God,
That is,
everybody's going in the right direction.
gosh, Nancy, that's such a great pearl. You're right, because it's true how that anxiety can really transfer onto patients, other family members, even teams. So thank you. That's an awesome tip.
And then you got somebody who's back on a plane, back to Anchorage when it didn't need to be.
Right.
But if you get the worry and get them calmed down, we're good.
Okay. Exactly. Mary Campbell and Wrangell, I saw you shifting around. Did you have some input for that? We're lip reading. You can use your,
yeah.
You can hear us now, yep.
No, we're out in the boonies out here, so a lot of what you were talking about is we use, like as you were talking about, who's in the family, who's power of attorney. The advance directives and power of attorney are two things that we do habitually when people come in or on swing bed status, or certainly for long-term care. But I'm trying to hit as many of the acute care patients that come through here that I can. If I have time, I'll try to hit them too and go over the advance directives and power of attorney forms that we already have on file here in the hospital to make sure that they're current. Resources, we tend to be a little bit creative out here. Of course, we don't have hospice here. We are delighted that Search has taken this over as of November the 1st, and we're hearing that we are in the plans of adding home health to us as soon as they get their survey done on the Sitka home health, so that be a part of that. It won't be a new something. And then, we don't have hospice here, but we do have a volunteer hospice group. When we first started talking, you were talking about the volunteer hospice group, and we have a pretty active group of, there are probably about 10, 15 of us who try to be mindful about who needs some help in the community. And we recently renamed ourselves from the hospice group, because that has, the word hospice has all of that meaning associated with it. We don't want to be associated with anything called hospice. So we've kind of renamed ourselves Harriet's Helpers. And and Harriet Shermer was a physician who came to Alaska in the mid-50s, 1955 or something. Came to Alaska as a physician and worked out in the boonies, and she was here in Wrangell for many years, and people loved her, and she died about a year and a half ago, and we named something. She actually started the volunteer hospice group, but we named ourselves, Harriet Helpers is kind of good. So we're just pleased to be here, and really appreciate so much that we can be part of your conversations, and a lot of things that you do are things that we do.
Thank you, Mary. That's awesome. I really like that. We do have some of those discussions over here too about how do you really integrate a team of support into a family without saying hospice, without saying palliative care. They Google that and all of a sudden they don't need you. So really good food for thought there. Thank you for that.
Yeah.
Sean?
Yeah. Do we have time for one more?
Yeah,
Okay.
actually, I want to take this conversation a little bit further because I think it's really important.
Sure. I just was going to go back to what Nancy had said. I really appreciated not settling for there's no questions or we're okay with the plan, but finding the people who could be worried, digging a little bit deeper. Because I think, unfortunately, our patients often, the place is so important, or just getting out of the hospital, they're willing to accept a less than perfect plan with a lot of holes in it. And so it's really, the burden is on us, not just on the patients to advocate for themselves. We really have to dig deeper. We can do a better job, and particularly when it comes to end-of-life care. So being proactive, knowing what common issues are, making sure we bring those up. If this situation occurred, how would you handle that? Finding some key, expected situations they may have to deal with, and making sure that's part of the care plan as well. Because unfortunately, if we don't come up with good plans, the outcomes won't be what we want to be, and then patients will start making different decisions, even though they'd like to be home or like to be back in their communities, we may find that eventually people will want to come to the hospital instead, or a different community altogether, which could be a real tragedy for those who would like to stay home.
And great point. The other thing that I just like to add as far as a pearl, I think so important to really, really clearly articulate to both the family and the healthcare staff in the place that's accepting that patient, really what are the expectations of the roles. So many times we send patients and families out into the boonies to marry, and you know, it's a struggle. There's an expectation of the way that the healthcare should, or the health aid should be engaged, or there's an expectation of you know, that they are going to have that net of safety, like what Sean was saying. But when they actually get home, maybe they don't have family members who are going to be able to offer respite and really identify, kind of poke holes. I mean, that's our job as well. So many times we focus on trying to get people out of the hospital, but it's our job to poke holes into plans to make sure that they're not bouncing right back to us. So thank you. And also, a plug for Afghan, we have that available to the regions for our specialty team. So if you have patients out there that you're struggling with in the rural sites, please know that you guys can send a referral to our team, and we would be happy to do chart reviews, make recommendations formally and informally, so that we can support you guys a little bit better. So does anybody else have any insight or did I hear a little peep?
No, just peeper.
Okay. Mary, did you have a peep? I think Mary's trying to get off mute.
Yeah, I think I had some additional noise that was coming in from someplace else, and I had forgotten.
Okay.
I couldn't finish, so I tried to mute myself. Sorry.
Lorraine, I know I'm going to pick on you out there. I know you're out there. We can't see your face, but I know you're there. Do you have any other parting thoughts for us as far as being Village Health Aid on the receiving end that you guys want us to be really mindful of, and that's very helpful for you in order to accept somebody who's, you know, really kind of intense?
Well, as told before, just everything that she said earlier, being on the same side, you know, communication is a big plus. With us going out into the communities, like that one time we went out, the doc and I, and both of us not even knowing that we were both coming at the same time on the same plane, and had a terminal ill patient in the village until we actually got to the clinic.
Oh boy.
That was quite the adventure, but now that we have this team, I think it's going to work out really well.
Yay.
Sin is a #1 plus too, because a lot of the problems with that one situation was the medicine and the weather and no mail. There was no way to get the medicine to anybody at the plane. It was just one crazy situation.
Yeah, and thank you, Lorraine, because that's so stressful for the providers who are witnessing the struggle, and also for the people that are experiencing the struggle. And so I think that kind of brings back what Sean was saying and what our team's been saying about the being proactive, not necessarily really having a solid plan A, but what is plan B, and how do we pull that cord, and how do we access kind of emergency plans?
And
so
actually in the doctor's office with the very first time that the patient and the family are told, you know, we need some compassion in that room.
Yeah.
Someplace that's more comfortable than a room way in the back, and you know, the doc just comes in, tells you you have cancer, and then leaves the room, and that's it. And you sit there for 20, 30 minutes before someone else comes in, and you and the patient are in tears because you just found out your family member has cancer. That was really disturbing.
Yeah, thank you for that. We certainly have a lot of work to do, don't we?
We do, and this is progress, though. Hey, we have this palliative care. That's amazing.
Yay! So we can't do it without you. I mean, we all rely on each other to really find those gaps. How do we fill them creatively? How do we support one another? How do we learn from one another? So thank you guys for participating. It really sure helps what we're doing and helps us keep our patients at the front of what we do.
Go
ahead.
There are many health aides, not only myself, that have great ideas, and we're always here just to email away or a phone call.
Yay. Thank you. I hope that when you're talking to your chat friends that you will kind of encourage them to participate, because your knowledge and your expertise and your suggestions and your creativity are they're invaluable to our teams here in Anchorage. We think we're so resource heavy, but sometimes we can't do half of what you do out there with nothing. So we really sure appreciate that guidance.
Well, thank you.
Yeah. Yay! There's so much love here before the holidays. So on that note, I'm going to transition us over to our introduction.